Okay, thank you. First half an hour we'll discuss regarding the history point, and the next 1 hour will go regarding the examination. Okay, so mainly the cardinal symptoms come pertaining to the respiratory system means mainly first is cough, followed by breathlessness, then chest pain, hemoptysis, pedal edema, and any hoarseness of voice. So these are the cardinal symptoms pertaining to respiratory system. So what is cough? So cough is actually a protective reflex, that is expression against a closed glottis. Okay, so history I will be just running fastly for the next first half an hour. Then after that, next 1 hour examination will go better way. Okay, so there are cough is of two types mainly. That is a dry cough is there, and there is a productive cough is there. As you will all know, that dry cough can be because of causes like foreign body aspiration, or it can be because of acute severe asthma. It can be there, or it can be because of a gastroesophageal reflux disease also. But productive cough is most of the time it will be an infectious causes like suppurative lung diseases. So whenever somebody asks you regarding some causes, always better to remember suppurative lung diseases like bronchiectasis and lung abscess and emphysema. These three you can remember as the cause of anything like productive cough or any cough with foul smell, anything. All these causes you can remember easily, like productive cough causes are suppurative lung diseases. Tuberculosis can be another reason, and you can think of always remember about bronchiectasis. And there can be a diurnal variation of cough can be there, or there can be a postural variation of cough can be there. So these are mainly feature of bronchiectasis. And now you have to know there are some particular characteristics of some cough, like bovine cough, barking cough, and there can be something called brassy cough. So this brassy cough means, brass means it is a metal. So the brassy cough, it is a metallic character of sound will be present for the cough. So this is mainly present in intrathoracic space occupying lesions. Like any tumors are there, they can have mainly metallic cough or the brassy cough can be there. And then bovine cough. So bovine means what? It is animals. Okay. So when a cow is making the sound, it's not having that explosive nature of the cough is not there. So when the man is coughing similar to that of an animal, that explosive nature of the cough is lost for somebody, that means the recurrent laryngeal nerve is not working. So whenever there is recurrent laryngeal nerve palsy, they can have something called as bovine cough. Now next is barking cough. Barking cough, you know that it is mainly seen in hysteria, like somebody is not having the cough. For example, you didn't go to the class for last 1 week. Next day you went to the class, you want to tell that you had a fever and cough, but you, before going to tell, you will make some imitations of a cough. So that is called barking cough. Actually there is no cough is there, but it will mimic like an automatically made a cough. So that is called barking cough seen in hysteria. Now let us see a description regarding the productive cough. So if the productive cough is there, it may be, there should be a sputum should be there. So there is something called sputum can be less than 30 ml or sputum can be normal sometimes. So when the cough sputum is very much more than 100 ml per day, sputum is coming a day, it is called as bronchoria. So bronchoria means sputum production more than 100 ml per day is called as bronchoria. Now next is we have to know the color of the sputum, and you can tell what is the infection that is there. So if there is a green color sputum is there, that is mainly seen in bacterial infections. Green color sputum is seen in bacterial infections, especially Pseudomonas. Pseudomonas is the reason for all green color discharges. Okay. Next is black color rusty sputum. Black color rusty sputum is seen in pneumoconiosis, cold workers pneumoconiosis, like that. And red currant jelly sputum, that is seen in Klebsiella. Red currant jelly sputum is seen in Klebsiella. Next is pink frothy sputum. Pink frothy sputum seen in pulmonary edema. It is a very severe condition, and they will tell in auscultation also you can see that there is something called a red death rattle is there. It is similar to the death rattle. So if that sound, that type of crackles you are hearing, the patient can have an impending death also. So pulmonary edema is a very acute severe condition that you have to manage aggressively. Next is you have to know that the sputum can be serous, mucoid, mucopurulent, like that also you can differentiate. And next is hemoptysis. So blood tinged sputum, that is coughing out of blood, is called as hemoptysis. The differential diagnosis mainly hematemesis, that is the vomiting out of blood is called as hematemesis. So you have to know in exam time they will ask you how to differentiate between hemoptysis and hematemesis. So hemoptysis is coughing out of blood. So preceding cough will be there. Hematemesis is vomiting out of blood. So they will have preceding vomiting, nausea will be there. And in the GI tract, there is acid is there, acid hematin. Okay, GI tract, there is something called acid is there, that is the acid hematin. So this acid will mix with the heme, means the acid is there, that acid is mixing with the blood that is forming the heme, leading to acid hematin formation. This is of dark red in color, So hematemesis will be dark red in color or dark brown in color, while fresh red color is seen in hemoptysis. Okay, and next is this hematemesis is mainly because of upper GI bleeding. Upper GI means the cutoff point between upper GI and the lower GI is ligament of Tietz, something called ligament of Tietz, that is mainly present in the second part of the duodenum. So that bleeding that can happen above the ligament of Tietz, that is called as upper GI bleed. It will lead to melena. So melena is, black color, sticky, tarry stools that is adherent to the pan of the toilet. So melena will be associated with the hematemesis. It won't be associated with the hemoptysis. Another differentiation is pH. The pH will be acidic in hematemesis. It won't be acidic in hemoptysis. And you have to know two terminologies that can be asked in your viva, something called as pseudo hemoptysis and spurious hemoptysis. Pseudo hemoptysis and spurious hemoptysis. Pseudo means it is not original. Spurious is also not original. So pseudo hemoptysis is actually, it is a pigment that is produced by bacteria which is red in color. That pigment name is called prodigiosin. 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 Okay. So that is the pigment that is leading to red color. It will lead to hemoptysis. It will mimic like hemoptysis. That is why it's called a pseudo hemoptysis. Next is called spurious hemoptysis. The spurious hemoptysis means it is mainly because of upper respiratory tract bleeding. It is not lower respiratory tract bleeding. The original hemoptysis is the one that is coming from lower respiratory tract. Respiratory tract. If it is from the upper respiratory tract bleeding, it is called as spurious hemoptysis. Next is, you have to know that we finished about the cough and the sputum thing. Next we will go to breathlessness. So history will try to finish within the next 20 minutes history. So breathlessness is mainly awareness of one's own breath. That is mainly breathlessness. So when we are breathing, we are not understanding that we are breathing, but when you are feeling that you are having that exceptional breathlessness, that is always abnormal. So, but when you are running or something, it can happen normally also. So there is a grading system is there for respiratory system, and the classification system is there for CVS system, cardiovascular system. So respiratory system, it is the MRC, that is a Medical Research Council. Later on, they modified it to Modified Medical Research Council. So this is the one. Then after that, it is changed to Modified Medical Research Council. But in CVS, it is NYHA, that is a New York Heart Association system. So MRC, this another MRC classification that is also seen in power grading of CNS. Power grading in CNS is also by MRC grading. So MRC, it is a Modified Medical Research Council grading. Remember, this is used for respiratory system. NYHA is used for cardiovascular system. So you are going after when you are going at your own pace, after the class or evening time, you are going with your own speed, and you put a headset in your ears, you are walking. That time also you are getting the breathlessness. That is abnormal. Like walking at your own speed. Another is walking with the peer age group people. You are going with your friends and you are getting breathlessness, but your friends are not getting breathlessness. Another one is hurrying on a level ground or walking an uphill. This is another grade. So what are these grades means? When you are hurrying on a level ground, you are walking very fastly, or you are walking an uphill. This is mainly because of called as a grade 1 breathlessness. And grade 2 breathlessness means when you walk along with your peer age group people, you alone is getting breathlessness, but your friends are not getting breathlessness. That is considered as grade 2 breathlessness. And grade 3 is the one that is happening when you are walking at your own speed. When you are walking at your own speed, still you are having breathlessness, that is considered as grade 3 breathlessness. Next is grade 4. Anything that is present at rest is considered as grade 4 breathlessness. So next is you have to know the chest pain. So in respiratory system, the chest pain, and cardiovascular system chest pain, how to differentiate? You know that there is something called angina, and the typical anginal pain can be there, or atypical anginal pain can be there, or it can be non-cardiac chest pain can be there. So cardiac pain, cardiac chest pain is usually central or the retrosternal area it is present, which is of constricting and squeezing type of nature, which is of constricting and squeezing type of nature. That is what is called as anginal pain. This anginal pain will relieved by taking the rest and by taking nitrates. Nitrate is a vasodilator. The anginal pain usually lasts for 2 to 20 minutes duration. These are the features of typical anginal pain. If these are not coming all together, it can be considered as atypical. Only one is coming like that, you can consider as atypical chest pain. But the thing is, anginal pain, it will go up to the jaw, or it can go up to the epigastrium. It does not process below the epigastrium, and it does not go above the jaw. So this is the distribution it can happen. Usually it is radiating to the left shoulder. It can sometimes radiate to the right shoulder also. It is not like it can go only to the left shoulder. But if it is a pleuritic type of pain, it is usually present in the lateral aspect of the chest, which is increased on coughing, or increased on taking deep inspiration, increased on coughing and on taking deep inspiration. That you need to know that it is called as pleuritic type of pain, which is present in the lateral aspect. So next common history that can happen is wheeze. Wheeze is the auscultatory component of rhonchi. So you will hear that whistling sound. That is the wheeze. So expiratory wheeze can be there, or it can be present inspiratory also. Now there can be somebody can present like hoarseness of voice also. This hoarseness of voice, it can be because of recurrent nerve involvement, or it can be sometimes it can be because of neurological causes also. Like for example, not only the nerve involvement, like myasthenia gravis. These people can have a hoarseness of voice by the end of the day. Then they have bulbar myasthenia. So myasthenia mainly usually occurs in the ocula, but if it is occurring in the bulbar region, that means the throat area, if it is affecting, it can lead to evening time hoarseness of voice, evening time difficulty to swallow, all these things, nasal regurgitation of food, all these things can happen. Then common thing is fever. That I'm not describing now. Fever, you have to know the types of defined fever. When you have to tell it is fever, that is a basic question you should know, because if you don't know the fever in exam hall, it will be very difficult to tell. So WHO definition of fever: morning time temperature more than 98.9 degrees Fahrenheit, and evening temperature more than 99.9 degrees Fahrenheit describes the fever. So always the evening time, the temperature will be more for everybody compared to the morning time because of basal metabolic rate. This basal metabolic rate will be more in the evening. So that is why more temperature is kept as the baseline for defining fever. And you should know the types of fever: continuous, remittent, intermittent fever. The causes of all three types of intermittent fever you have to know. Palpation fever, what is that you have to know. So these are the things you should know regarding fever. Now, in past history, in respiratory system, you are mainly asking history regarding tuberculosis. You have to ask. When you ask regarding history regarding tuberculosis, you are supposed to ask that whether there is a drug default has happened, whether any relapse has happened or not, or these things you have to ask, and how many months he has taken the treatment, all these things. Okay. And any history of chest drowning, or any history, if it is a kids pediatric cases, you need to ask history regarding fever with exanthematous rashes. For example, in cases like varicella zoster, in cases like measles, they can have involvement in the lung also. Because of that reason, you need to ask these histories also. Any history of seizures recently, any history of trauma, any history of drowning, these are important. Seizures, drowning, these are related to aspiration pneumonia. So that is why the importance respiratory system. Now coming to the family history or the contact history, you need to ask regarding anybody in the family is having any similar illness. And another thing is bronchiectasis. there can be multiple syndromes are there for bronchiectasis, lung abscess, and all. So you need to know the family history for that reason. And coming to the examination part, now we will go to the examination part. The brief history we have told about that regarding the respiratory system. Now we will discuss regarding the examination part. When you come to the general examination, you will write this pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, and pulse rate, BP, head to foot examination you will write. You need to know that for a particular system, you need to write something extra. If you write that, then only you will get more marks. Otherwise, you may pass, but you have to get some more marks because of that reason. So respiratory system, you need to write any external markers of tuberculosis is there or not. And you need to write any external features of Horner's syndrome is there or not. Any external features of SVC obstruction is there or not. These are the three things you need to write extra things in respiratory system, like external features of tuberculosis, external features of Horner's syndrome, external features of SVC obstruction. And one more thing, if you don't know these things at all, you don't mention this, because questions sometimes will go to that direction also. If you are telling about a CBS case, you need to know that you have to tell any external features of rheumatic fever, any external features of infective endocarditis, and any external features of atherosclerosis or congenital heart diseases. This is what you have to tell in cases of CBS cases. In case of abdomen case, you need to tell any external features of liver cell failure. In case of an ascites case, you have to tell any external features of liver cell failure is there or not. When you come to CNS, neurology cases, you need to tell about any neurocutaneous markers are there or not. Any neurocutaneous markers are there or not. Next is any features of brain cervicomedullary abnormality, craniovertebral junction anomalies are there or not. Any features of atherosclerosis is there or not. These are the main things you want. Any musculoskeletal abnormality. Musculoskeletal abnormalities you need to tell in every system. Now coming to the respiratory system pattern, general examination. So first you have to tell about the build of the patient. No? When you are telling about the build of the patient, for a thin, lean person in respiratory system, they can also can happen. You will tell moderately built and nourished. So built is the skeletal structure, nourishment is the nutrition, like the muscle part. So and also vitamin deficiency, everything will come under nutrition part. So built and nourishment. In the built and nourishment, for a thin built person in respiratory system, they are more prone for developing pneumothorax, spontaneous pneumothorax. That is the main thing. Spontaneous pneumothorax can happen in thin built people. Then anemia. Then coming to the pallor thing. So anemia, how can anemia can happen in a respiratory system case? One is they can have something called as bronchogenic carcinoma. If they are having bronchogenic carcinoma, they are prone to develop anemia. Another thing is that if somebody is having a COPD is there, they will have polycythemia. They expect opposite thing. And in tuberculosis or any chronic diseases, like anemia of chronic disease can happen in any chronic diseases. For that reason, you have to know why anemia is important. Another thing is sputum production is more in tuberculosis. Sputum contains albumin. So this protein, that is a protein. These proteins are needed for the synthesis of ferritin also in the body. So ferritin is the storage form of iron. So in that form, it can develop one thing. Another is by means of interleukins. So it can lead to anemia of chronic disease. So that is another mechanism. So any of these things are, if it is happening, they are prone to develop something called as anemia of chronic disease. When polycythemia and COPD, there is a relation between polycythemia and COPD is also there. And next is COPD, this polycythemia can happen also in paraneoplastic conditions also. As a paraneoplastic syndrome also, anemia, polycythemia, this also can happen. Now next we'll see about regarding the pallor, icterus, cyanosis. We'll go to cyanosis. So cyanosis can be of peripheral cyanosis and central cyanosis can be there. So this peripheral cyanosis is mainly happening in the extremities of the body, while central cyanosis is mainly happening around the mouth, that region. So you have to know the causes of the central and peripheral cyanosis. The central cyanosis is mainly because of decrease in the oxygen carrying capacity of the body. So when the reduced hemoglobin more than 5 gram is happening, then only the cyanosis will appear. So sometimes a question can arise whether severe anemia can they produce cyanosis or not. When somebody is having a hemoglobin of 3 or 4, they will not manifest as cyanosis because the reduced hemoglobin should be more than 5 grams to manifest cyanosis. So they will not have cyanosis at all. So that is how to differentiate between, that is the main thing. You have to know whether there is anemia can manifest without cyanosis also, while polycythemia, there can have a pseudo cyanosis presentation also. Next is central cyanosis can be of two causes mainly. One is because of oxygen carrying abnormalities. So for example, if there is having a respiratory pathology is there or cardiovascular pathology is there, they are having the oxygen carrying capacity is reduced because of that reason. Second thing is hemoglobin abnormalities. You have to know hemoglobin abnormalities also causes central cyanosis. Then how to differentiate? You give oxygen to the patient. If it is improving, that is mainly it is a central cyanosis. Not improving, it can be because of hemoglobin abnormalities. If it is not because of oxygen carrying problem. So methemoglobin, if it is more than 1.5 milligram per deciliter, methemoglobin more than 1.5, it is not 5 as per reduced hemoglobin. Reduced hemoglobin more than 5 gram was there. But if it is methemoglobin, if it is more than 1.5 gram and self-hemoglobin more than 0.5 grams, then also they can develop something called as central cyanosis. So central cyanosis can be because of hemoglobin abnormalities also. Peripheral cyanosis, you know that when you are exposing to the extreme cold climate, when you are exposed, they can have something called as peripheral cyanosis. Next, there is something called differential cyanosis is there. Any one of the limbs is there, only upper limb is there or lower limb is there, like that it can happen. That is mainly seen in PDA, patent ductus arteriosus. Next is clubbing. We will go to clubbing. So clubbing is what? Bulbous enlargement of the distal phalanx due to deposition of subungual soft tissue. Bulbous enlargement of the distal phalanx. This is the distal phalanx due to deposition of the subungual soft tissue. Subungual means beneath the nail. Subungual soft tissue deposition if it is there. So there is an angle is there. This is called as a Lowy bond angle. So the angle between nail and the nail bed, this is called as the Lowy bond angle. This should be less than 160 degree. Should be less than 160 degree. If it is more than 180 degree, it's called as obliterated Lowy bond angle. Obliterated Lowy bond angle. And you might have seen something called as always the clubbing first appears in the index finger. Clubbing first appears in the index finger. Index finger is the first one that is appearing. And there are multiple theories of clubbing is also there. Multiple theories like hypoxic theory, vagal theory, then platelet derived growth factor theory, like multiple can be there. The mostly accepted theory is called as platelet derived growth factor theory. That is the most accepted theory of clubbing. And when you see the clubbing in the respiratory system, you can see that there is something called a Shamrock sign is there. This is how to examine for Shamrock sign. That means when you keep both the fingers, there should be a diagonal shaped space should be there. If the diagonal shaped space is not seen there, that is called as obliteration of the Lowy bond angle or the positive Shamrock sign is there. So, okay. So now we are going to grade the clubbing into 4. You can remember something called mnemonics like OPDH. OPD in the hospital. OPDH. Okay. So obliteration of the Lowy bond angle is O. P for parrot beak appearance. Okay. P for parrot beak appearance. Parrot beak will be always only anteroposterior increase will be there. And when you see grade 3, that is a drumstick appearance is there. Drumstick. Drumstick is looking like a lollipop. So when you see that, you can see that anteroposterior diameter and transverse diameter both will be increased. So only the anteroposterior diameter is increased, that is considered as parrot beak appearance. When anteroposterior and transverse diameter both are increased, that is considered as drumstick appearance. And another one is called hypertrophic osteoarthropathy. That is a grade 4. Hypertrophic osteoarthropathy is called as a grade 4. So remember that hypertrophic osteoarthropathy, they will have tenderness of the joints. Tenderness of the joints will be there. So when you take an X-ray and see that, you can see that angle joint, there is new bone formation also can be there. That is called hypertrophic osteoarthropathy. This is mainly seen in lung carcinoma, or the bronchogenic carcinomas are the most common cause of a hypertrophic osteoarthropathy. Okay, now let us go to the other signs like anything. Then edema. How can edema can happen in a edema? How can you relate between respiratory system and edema? So this pedal edema is mainly because of two things you have to know. One, it is respiratory system can lead to cardiac failure. That is called as cor pulmonale. Cor pulmonale is one of the reason. Another reason you have to remember is hypoalbuminemia. Hypoalbuminemia. Protein is losing through the sputum continuously. Protein is going out. So that sputum contains full of protein. That albumin is losing. So that can lead to hypoalbuminemia. It can lead to reduction in the oncotic pressure, which can lead to pedal edema. So this is another cause of pedal edema. If suppose there is edema of the hands are there, edema of the hand is there in a respiratory system case, along with this dilator veins are there on the thorax, then you have to know that it is SVC obstruction. You have to know it is SVC obstruction. The patient can have edema of the hands alone, but there is no edema of the legs with the dilator veins over the thorax. Now you have to know that there is something other things I told you, like external features of tuberculosis. You have to know what are the external features of tuberculosis. When you see the eyes, you have to always look general examination from head to foot. When you see the eyes, you can see something called iridocyclitis can be there. Iridocyclitis. So iridocyclitis, flictanular conjunctivitis. Another one is flicten. Then you see studied ophthalmology, you can know there is something called flictanular conjunctivitis is there. When you see the eyes, iridocyclitis and flictanular conjunctivitis can be there. And when you see the sinuses, there can be sinusitis can be there, or big nodules can be there at the neck region. That is going to be considered as scrophallodema, and there can be lupus vulgaris. This lupus vulgaris means it is actually the skin tuberculosis, or the cutaneous tuberculosis is called as lupus vulgaris. An MCQ question they can ask is apple jelly nodules. This is seen in where? This apple jelly nodules are seen in lupus vulgaris. This is a typical hallmark picture of lupus vulgaris. Okay, this vulgaris means it is not vulgar, it is a common term, commonest, that is the meaning. Acne vulgaris, lupus vulgaris, like that, that is a commonest, that is the meaning. Okay, so next is erythema nodosum can also be there. It's a external markers of tuberculosis. Or any discharging sinuses in the body, that can be one of the reason for somebody is having as a tuberculosis. These are the external markers of tuberculosis. And Horner's syndrome, why it is important means the it is mainly present in the cervical sympathetic ganglion chain is there. If there is a pathology, some compression is happening at the cervical sympathetic chain. Okay, if some compression is happening at this region, it can lead to Horner's syndrome. You have to know the components of Horner's syndrome also. So how that compression can happen? The superior sulcus tumor, some tumor is there in the upper part of the lung, it can go and compress that. So that can lead to external features of Horner's syndrome, it can cause. And any external features of SVC obstruction as like one edema of the hands alone, but there is no edema of the legs. And there can be dilator veins are there in the thorax. So this is how to know that there is any feature of any SVC obstruction is there or not. So you have to tell all these things in patients with a general examination. And always don't forget to mention BMI in patients in all general examination. Okay. Now let us go to the respiratory system examination proper. So respiratory system always starts, always you have to tell that from the nostrils, from the ear, the nearest external ears itself, you have to start the respiratory system examination. And always mention in cases of CBS and RS, always mention regarding the oral cavity, dental hygiene, everything. Because If there is an oral cavity halitosis is there, you can think it is a suppurative lung diseases. Otherwise, when there is dental caries are very high, the chance of infective endocarditis is there, like that. So oral cavity examination is also important in cases of a CBS and RS. And fetal hepatitis can happen in abdomen. So all three systems, every systems, it is very important to examine for the oral cavity. You have to mention the dental hygiene. Okay. Now, coming to the external nasal cavity, you have to know that there is a nasal septum, if it is deviated or not. It can be deviated in most of the people, or otherwise any inferior terminate hypertrophy is there or not, you can just see. And you can just tell that any mucus discharges is there, nasal polyp if it is there or not, or any granulomatous lesion or anything is there. This is what you are supposed to examine in external or the upper respiratory tract examination. This is the upper respiratory tract examination. When you are coming to the oral cavity, examination, what you have to know is, you have to know that dentition, halitosis is there or not, dental caries is there or not, or oral candidiasis is there or not. So oral candidiasis, if it is there, you can know that the patient is having immunosuppression, immunocompromised state it is there. Now, next we are going to the respiratory system examination from inspection. All examination includes mainly inspection, palpation, percussion, and auscultation. So in inspection, first thing is you will tell about the position of the trachea. Then shape, apical impulse you have to know. Shape and symmetry of the chest you have to know. And any intercostal indrawing is there or not. Supraclavicular fullness or hollowness is there or not. And any drooping of shoulder is there or not. And respiratory movements, how is that? How is the accessory muscles of respiration? And whether there is any dilated veins, scars or sinuses there or not. This is much is the things you have to know when patient is having inspection in case of a respiratory system. So position of the trachea. Whenever you are examining for respiratory system, always examine in sitting position, not in supine position. So sitting position, patient should be there. The head should be straightened. It should be fixed like this. Okay. And then you feel for that. Then you have to look in inspection. If the sternocleidomastoid on one side, if it is becoming more prominent, that is abnormal. The head should be straightly fixed. And when you are seeing, if you are feeling the sternocleidomastoid on one side is more prominent, that side is the trachea deviation present. So trachea is deviated to the side whether there is a lesion can be there or it can be there on the opposite side of lesion. But always remember, sternocleidomastoid prominence will be on the side where trachea is deviated. This is because of relaxation of the pretracheal fascia. This is because of the relaxation of the pretracheal fascia. So you know that there is a multiple fascia called is a layer, no? So out of that one is called pretracheal fascia. So if the pretracheal fascia is loosened, it can relaxation is happen. It can lead to sternocleidomastoid prominence of one side. This is called as trail sign. TRAIL sign. Trail sign. So if the trail sign is present on one side, that side is the trachea deviation. That side is the trachea deviation. So then, so how to know which side is the lesion? There is something called pushing type of lesion is there and pulling type of lesion is also there. Central trachea is there, and if the disease is present on this side and the trachea is pushed to opposite side, that is called as pushing type of lesion. And if the disease is on this side and the trachea is deviated to the same side of the lesion, that is called as pulling type of lesion. Disease is pulling the trachea to its side, that is called pulling type. Disease is pushing the trachea to the opposite side, that is called as the pushing type of lesion. So this pulling type of lesion, for example, center one person is standing and this side one big crowd is there. Some 6-7 people are there. This side only one person is standing. So automatically the trachea will have a tendency to the, when there is a more space is there, will go to that side. Okay. So here 7 people are there, here only one person is there, he will automatically move to the side where only one person is there. So that is called pulling type of lesion. It means there is more space is there in my lung on left side, and my lung is making the trachea to come to the left side. That is called pulling type of lesion. Seen in collapse it can be, or it can be seen in fibrosis. When the lung volume is fully lost on one side, the trachea will have to shift to that side. That is called pulling type of lesion. Now, pushing type of lesion can be there. Like disease is present on one side, but trachea is pushed to the opposite side. Like if my trachea is here, if there is a big bag is coming and hitting me from here, it will go to opposite side. So this big bag can be a big bag of fluid. It can be, or it can be big balloon. The balloon you need to imagine it is a pneumothorax, and the big bag that is full of fluid, that is the that is a pleural effusion. So pleural effusion and pneumothorax, the trachea will be shifted to the opposite side. Trachea will be shifted to the opposite side in case of a pleural effusion and a pneumothorax. Trachea will be shifted to the same side in case of fibrosis and collapse. And trachea will be in the midline in two conditions you have to know. That is mainly COPD and consolidation. COPD and consolidation is there. The trachea will be there in the midline itself. Trachea will be there in the midline itself. Always don't confuse, because consolidation and COPD, you have to know that trachea is present in the midline itself. There is no deviation at all. So this trachea deviation mainly happens in the upper apical lobe of the lung pathologies. Apical lobe of the lung pathologies. If it is a lower lobe pathologies, this trachea may not have shifted only. Like lower lobe fibrosis or collapse is there, it may not shift. What is going to happen then? That problem will be in the apical impulse. This is why the importance in respiratory system, the apical impulse is shifted outwards on inwards. The apical impulse will be shifted inwards if there is a lower lobe collapse or fibrosis is there. Okay. Now, next is you have to know that there is any drooping of shoulder is there or not. So drooping of the shoulder means you have to always look from behind the patient. You have to stand behind the patient, and when you look, you have to see that if there is a two shoulders are here like this, means one shoulder is at the lower level, one shoulder is at the lower level, other shoulder is at the higher level. That means that wherever the lung is collapsed or fibrosis is there, that side the shoulder will be drooping of the shoulder will be there. So but normally the shoulder should be equal. If there is a drooping of shoulder is there on one side, you have to know that there is a lung volume loss has happened. It can be because of fibrosis or collapse. And when there is something called a supra, this is you have to make the patient in standing position. You have to stand behind the patient and you have to observe. Then only you can know there is a drooping of shoulder, not in sitting position, preferably in standing position. If no other way, you can make the patient in sitting and examine. But never examine in supine position any respiratory system case. Okay. Now, any intercost, any supraclavicular fullness or hollowness. This is a supraclavicular region. Supraclavicular region. This is any fullness is there or hollowness is there. Supraclavicular region. So, if this region, if it is becoming more collapse, fibrosis or collapse has happened, that will become full hollowness will be there. This will become a big hollow compared to the opposite side. The big gap will be seen. So that is called as supraclavicular hollowness. The supraclavicular hollowness is also a feature of fibrosis or collapse. So this is mainly seen in apical lobe of the lung, not in the lower lobe of the lung. So next is you have to know there is something called as respiratory movements is there. Respiratory movements. Always remember, wherever is the pathology, the respiratory movement will be diminished on that side. Respiratory movement will be diminished on the side wherever there is pathology is there, even if it is a pushing type of lesion or pulling type of lesion, or if it is the tracheus and the midline, whatever it is, respiratory movements you have to always remember whichever side is the pathology, it will be reduced. For example, fibrosis has happened here, it will be reduced on that side. If it is a consolidation happens here, it will be reduced. COPD happens, it is not localized, it is bilateral. So bilateral reduction will be there. And if there is a pleural effusion is there, respiratory movement is reduced. Pneumothorax is there, respiratory movement is reduced. Whichever side is the pathology, respiratory movement is reduced. This you have to know very much, because when you are doing the percussion or when you are doing the auscultation or everything, you will have a doubt. If you are not an expert, you will have doubt whether it is a normal percussion or whether it is a this side it is normal and this side is reduced, or this side it is increased and other side it is normal. You will have a doubt whether it is increased and other side is normal, or whether it is other side decreased and this side is normal. So examine for the respiratory movement, wherever side respiratory movement is there, that side is the pathology. So you will have doubt whether there is a right side or left side lesion is there. You need to know respiratory movement. So inspection respiratory movement, you will just mainly in adults it is mainly, females it is thoraco-abdominal type of breathing, and males it is abdominal thoracic type of breathing. Males it is abdominal thoracic and females it is thoraco-abdominal type of breathing. In pediatrics also it is thoraco-abdominal type of breathing. So if the problem is in the abdomen, what is going to happen? The abdomen is not moving much. The massive ascites is there. Abdomen is not moving much. Then what will move? That thorax will move more better. So thoraco-abdominal pattern of breathing is common in males, will be present in males in abdominal pathology. In females already it is thoraco-abdominal, it will be thoraco-abdominal. But when you see a respiratory system pathologies, you have to know that when the pathology is in the lungs, so thoraco will change it to abdominal thoracic. In males, it is already abdominal thoracic, it will be abdominal thoracic. In females, it will be already normal person, it will be thoraco-abdominal, but it will become an abdominal thoracic type of breathing if it is a respiratory pathology is more. That means their abdomen will move more better compared to the thorax. So that is the importance of respiratory movements. So next is you have to know the accessory muscles of respiration. So accessory muscles of respiration is nasalis can be there, sternocleidomastoid can be there, Hemoptysis can be there, all this, or in intercostal muscles, all these things. So the accessory muscles of respiration, if it is becoming more prominent, that means that he is having respiratory breathlessness. Especially one more thing you have to know, in pediatric patients, you have to know that there should be something called as intercostal indrawing is there or not. That also you have to examine. Intercostal indrawing is there or not. So in classification of pneumonias and all, they will use that. Okay. Now, next is any dilator veins are there in the thorax. As I told you, to know that there is a SPC obstruction is there or any IVC obstruction is there, you have to know that there is a dilator vein is there or not. In abdominal cases like spider navy or caput medusae can be there. So there also there will be dilator veins can be there. So you have to know that dilator veins. Any discharging sinuses or the scars in the body, that also you must tell. Always tell in examination whether the patient is having some scars. You must mention that. Even if it is a tattoo mark, you have to mention it is in general examination. So respiratory system, you have to tell about any thoracic area, any scars are there or not. For example, some ICD might have kept some days back. ICD, that is intercostal drainage tube, might have kept. So that can produce a scar there. So that is an important thing. Patient might have had a previous lung abscess. The pleural effusion can be there, or it can massive pleural effusion, or emphysema can be there. Now might have come with some other pathology. So that is the importance of checking for any scars is there or not. Any discharging sinuses can be there. So discharging sinuses also you have to know that it can be because of pathologies like a tuberculosis mainly. So this is the importance of inspection in case of one respiratory system. Now we'll go to palpation thing. So palpation, first thing is you have to know the position of the trachea. Position of the trachea, you have to do one thing called as 3-finger test is there, and another called as 1-finger test is also there. So some examiners may ask you what is 1-finger test, some will not ask that. Usually it is the 3-finger test that is performed. If you are asked to do it in the exam hall, you are supposed to do the 3-finger test. So head should be fixed. Head should be fixed, and your both hands should be on the sternocleidomastoid, on the middle aspect of the clavicle. You have to come down like this, and you have to feel that tracheal cartilage rings. Then you have to go on both sides of the between the sternocleidomastoid and the trachea. You have to palpate like this. If the trachea is deviated on one side, you will feel more resistance on the side. You will feel more resistance on the side where trachea is deviated. You will not feel that resistance when you are feeling the normal person. When you feel that resistance is more on one side, that side is the trachea deviation. This is by something called as 3-finger test. Next is the 1-finger test. 1-finger test, you have to come down like this. Always head should be fixed. Come down like this. Then you feel for the tracheal rings. If the tracheal rings is in a straight line coming down, that means that he is having straight trachea is in the center. Okay. So this is also you have to know that something called 1-finger test is also there. Position of the apical impulse, you have to know how to palpate. You have to palpate like this. Then you will use the ulnar border of the hand. Then you will point with a hand. This is how to check for position of the apical impulse. Another important thing is any chest wall tenderness is there or not, any local rise of temperature is there or not, you have to know. In surgery, you will check for the swelling. Why? Because any inflammation is there or not. Swelling is there, the temperature will change after you start palpating. So one more thing is temperature you have to examine using the dorsal aspect of the skin of the hands. So when you check for the palpation, local tenderness is there. If the tenderness is in the costochondral junction, it can be a costochondritis can be there. And if the tenderness is present in the intercostal space, it can be an emphysema. Emphysema can be there. Emphysema means pus. Emphysema is COPD. Emphysema is pus in the pleural cavity. Okay. So emphysema it is COPD and emphysema is the pus in the pleural cavity. So this is the main important differentiation you have to know. Localized temperature, it can be there in emphysema also, it can be there. Any inflammation, it can happen. Another tenderness, local tenderness reason is a rib fracture. If somebody has developed a rib fracture, you go and poke them, they will get surely pain. So that is a rib fracture. Then next is the respiratory movements. Respiratory movements, you have to know in anterior aspect there is a method of examination, posterior aspect there is another examination is there, and apical aspect there is another method of examination is there. When you look for the anterior aspect of the thorax, you have to keep both the hands in the axilla. Both the hands should be kept in the axilla and you have to bring the hands together in the front. Okay. Then tell the patient to take the deep breathing. Your fingers should be fixed in the axilla on both sides. Fingers should be fixed. You tell the patient to take the deep breathing. Then what will happen? This will move like this. Okay. Then you can compare your one hand is moving, other hand is not moving. That side is the pathology. So this is how to examine for the anterior aspect of this exam. Imagine that this is the body of the person and here I am keeping my hands and I am taking the breathing. These hands will move like this much. So if the one side it is not moving freely, that side is the pathology. Okay. This is for anterior aspect. Now coming for the apical lobe. Apical lobe, you have to keep your hands here. Here it should be kept. It should be kept in the back of the person. Okay. So you have to keep them on the back of the person. Your hand should be like this. It should be like this. In the previous area, when the anterior aspect you are checking, your fingers were fixed in the axilla and your thumb was allowed to move freely. Now, when you are checking for the apical lobe, your thumb would be fixed firmly and your fingers will be allowed to move freely. Okay. So this is where I am keeping my hands like this, and when I am keeping, when I am breathing, my hands will move up and down. My hands will move up and down. So this is how to examine for the apical lobe of the lung. You have to examine, keep the hands in the posterior aspect and you have to move it. The patient will take the breath, one side it is moving, one side it is not moving. So that will happen when there is something called as the apical lobe pathology is there. Okay. This is how to examine for the respiratory movement by apical lobe. Now, respiratory movement in the posterior lobe, how to examine means posterior lobe, you have to stand behind the patient. You have to stand behind the patient. Then you need to make a skin fold of skin. Okay. For example, how to make means I'll show you with a paper. So imagine this is the skin of the patient. This is the skin of the patient. I am taking the skin from the posterior aspect like this. When the patient is taking the breathing, this skin fold will move freely. So first thing, you have to take a skin fold of skin, and from the back of the person, this is the midline, this is the vertebra is there, and tell the patient to take the breathing and this will move freely. And the difference in one side, if it is more, that side is the abnormality, means less, whichever side is less movement is there, that side is the pathology. So this is how to examine for the respiratory movements in the posterior aspect of the body. Okay. So anterior aspect is your hands are fixed and the fingers are fixed. Your thumb is allowed to move freely. When you are examining for the apical lobe, your thumb is fixed and your hands are allowed to move freely. And when you are examining for the posterior lobe, you have to take a skin fold of skin, and this skin fold of skin will be allowed to move freely. This should be allowed to move freely. Okay. So that difference will be there, and that will give you the idea regarding the respiratory movements. Another thing is you have to know that chest wall inspiration and expiration should be measured. So inspiration and expiration you have to measure. So the normal difference between inspiration and expiration will be 3 to 5 centimeter difference. 3 to 5 centimeter is a normal thing. And if it is less than 3 centimeter inspiration expiration difference is there, that is considered as pathology. If it is more than 7 centimeters, some people can happen up to 7 centimeters also. For example, athletes, sport people, they will have good respiratory capacity. Because of that reason, they will be able to expand their lung very much better way. So you have to know when the respiratory pathology is there, respiratory movement, inspiration, expiration will be reduced. Another thing is you have to measure the left and right hemithorax separately. From here to the vertebra, you have to examine left and right hemithorax separately. You have to measure and you have to find the difference. Usually it will be equal, and if it is one side is abnormal, there can be a difference in the sizes can be there. So that is the importance of measuring the left and right hemithorax. Left and right hemithorax. Another thing is AP diameter and transverse diameter. So AP diameter and transverse diameter, how to examine means this is the anterior aspect and this is my posterior aspect. So I am keeping two books here. You have to keep one book in the front of the body, another book you have to keep at the behind your body, and you have to measure the distance between the two books. So that is how to examine for the AP and transverse diameter. One book is here, one book is in the behind, and the distance between both you have to measure, that is the AP diameter. And you keep two books on your both the axillas. Both the axilla you are keeping two books. You are keeping two books in your axilla. You are measuring the distance between these both. That is the transverse diameter. Normally the AP is to transverse diameter is transverse is 7, AP is 5. Normally AP is 7, AP is 5, and transverse is 7. When this becomes 1:1, you can imagine there is a barrel where water is kept, everything. The barrel will have shape of circle will be there. So the AP diameter will be equal to that of transverse diameter in a barrel shaped chest, which is seen in COPD. COPD, actually there are 3 types of COPDs are there. There is one is called emphysema is there, or it can be because of the blue water bronchitis can be there, and another one is called small airway disease or the small airway diseases. The 3 types are there. When you come to the exam hall, they may ask you. Previously it was considered only 2 were there, now it is considered 3 are there. Okay. So now we were telling about the AP and transverse diameter. AP is to transverse, if it is to normal, it is 5:7. 1:1 it is barrel shaped chest. Something called a flat chest can be there, which can see in fibrothorax or the lungs, fibrosis of the lungs. It can happen. That is common in tuberculosis, all the tuberculosis like AP is to transverse diameter. That means the AP diameter is very much less. The transverse diameter is very much more. So it will look like a flat chest. So AP diameter is double the size that of transverse diameter. So then it is considered as AP diameter is transverse diameter is double the size of AP diameter. It is considered as flat chest. It is considered as flat chest. Then there can be some abdominal shape chest can be like rickety rosary can be there, and scorbutic rosary, or it can be pectus excavatum, pectus carinatum. It can be there. Pectus excavatum means the center part of the lung. It is looking like of the thorax. It is like external. It is looking like a outside is protruded. Pectus carinatum means there will be inward dip will be there. So another thing is rickety rosary and scorbutic rosary. This medial aspect of the ribs that can become like a bead-like enlargement can be there. The bead-like enlargement. This bead-like enlargement, if it is a rounded, you need to think it is a rickets. And if it is sharp angulated edges are there, that is considered as scurvy. Sharp angulated edges are seen as scurvy. Rounded smooth ends are there, this is a rickets. So there is a rickety rosary and scorbutic rosary. This is the importance. Okay. Now, and we were talking about the AP and transfers. From there I went. Okay. Now we'll come back to the topic. So there's a right and left hemithorax you have to measure. I told you there is something called the spinoscapular distance you have to know. Another is something called as the spinoscapular distance. Okay. So I will show you. Okay. So if you see this, you can see this is the vertebra. Vertebrae are going like this here. Vertebrae are here, and this is the inferior angle of the scapula. This is the inferior angle of the scapula is there. So this distance between the vertebra and the inferior angle of the scapula you need to measure, and this side also you have to measure the inferior angle of scapula and to the vertebra. If one is reduced, inferior angle of scapula and the vertebra one is reduced, then you need to know that that side is a fibrosis or collapse has happened. If the other side is increased, you need to know that there is a pleural effusion might have happened, or it can be pneumothorax might have happened on that side. And another thing you have to know in palpation is there can be palpable breath sounds can be there. Palpable adder sounds can be there. So they are classified into multiple names like tactile fremitus, friction fremitus, and ronchial fremitus. Tactile fremitus, ronchial fremitus, and friction fremitus. The tactile fremitus means it is the palpable crackles that is seen in bronchiectasis. The crackles are getting palpated to your hands. That is the bronchiectasis. Friction fremitus. That is the palpable pleural rub. It is called as the friction fremitus. Palpable pleural rub is called as the friction fremitus, and palpable crackles or the rays, that is the one that is seen in bronchiectasis, and palpable ronchi, that is called as ronchial fremitus. Palpable ronchi is seen in ronchial fremitus. Okay. So this is palpable ronchi. This is mainly seen in bronchial asthma or in COPD. Bronchial asthma or in COPDs you can develop, or it can be seen in foreign body as some obstruction is happening, or it can be because of any tumors. There also you can develop palpable ronchi or the ronchial fremitus. Now, this vocal fremitus you know how to examine. That is another thing. And always remember, when you are writing from this vocal fremitus in an exam case sheet, vocal fremitus, percussion, breath sounds, vocal resonance, everything, you have to divide it into two columns, right and left. And every area should be written properly. Every area should be written properly, like supraclavicular, infraclavicular, then mammary. There is no inframammary area is there. In some books it is written there is inframammary area is there, but it is wrong. There is no inframammary area in respiratory system. Okay, so supraclavicular, infraclavicular, mammary, then you write suprascapular, interscapular, infrascapular, axillary, infraaxillary. You need to write it into different columns from vocal fremitus. Your case sheet should be written in columns. You have to remember that always. If it is normal, you write normal. If it is reduced, you write reduced on one side. Compared to the opposite side only, you can write whether it is decreased or increased like that. Okay. So vocal fremitus, you have to use the ulnar border of your hand. You have to use your ulnar border of the hand. You keep the hands. You can tell the patient to tell 111 or 99, 111 or 99. Like each and every intercostal space, you are going to keep your hands and feel for the vibration sense. If you are getting the vibration sense reduced on one side, that means that the vocal fremitus is reduced. If it is increased on one side, that is increased. So this is regarding the comparison between the opposite side only you can tell the vocal fremitus thing. Okay. Now we will go to percussion. So percussion also you have to tell based on this thing. Direct percussion is there and indirect percussion is there. That mainly two things are there. Direct percussion means it is directly percussing over the clavicle. Direct percussion is done only in clavicle, not in other areas. So this direct percussion is done in clavicle. So there is something called pleximeter and plexar is there. Pleximeter is this finger and plexar is the other finger, and you need to do percussion in the over the middle phalanx. So how to do over the middle phalanx. And once you do the percussion, you don't keep your hands there. If you do percussion, you have to take it out. If you keep your hand after doing percussion over your middle phalanx, that is going to dampen the vibration. So when you do percussion, take it out. Percuss, take it out. Percuss, take it out. Okay. So don't keep here like that. If you percuss like that, sound is going to reduce. The vibration will be reduced. So percuss and take it out. So pleximeter and plexa. These are the two things. So there are multiple rules of percussion and all there. So first thing is you have to do the direct percussion is done over the clavicle. You have to stretch the skin downwards first. Stretch the skin downwards. You have to stretch the skin downwards. Then you do the direct percussion is done over the clavicle. Medial 1/3 of the clavicle is the area where you are percussing. Medial 1/3 of the clavicle you do percussion. You do on the other side also. Whenever somebody is telling you to examine for vocal fremitus, or even it is neurology, if it is a tone or reflexes, everything you always do on the opposite side also. You don't do on one side and tell it is normal or abnormal. You have to do comparing to the opposite side. You have to do every time. You have to do it on opposite side also. Okay. So how to know? So when you are telling about the vocal percussion thing, your percuss coming downwards, you have to percuss again. You again come down. There is and the cardiac region, there can be normally dullness will be there, and other areas is considered resonant note on percussion. So if the sound is coming very much high, that is called as hyper resonant note. So how to know that it is a hyper resonant note or not? You have to tune your ear for that. So for that reason, you can go and take an empty water bottle you take and percuss. You will hear more sound. That is what is hyper resonant note. Hyper resonant note. Resonant is the one that you are hearing on the normal lung. And when you do percussion over, you just percuss over your thighs. You just percuss over your thighs. That sound is called as the dull note or the impaired note on percussion. Impaired note on percussion. And when you do this, you have to just percuss the wall. You just percuss the wall. If you percuss the wall or the stone, you will get pain over your fingers. If you get pain over your fingers, that is considered as stony dullness. That is considered as stony dullness. So this stony dullness, this is mainly present in where pleural effusion, it will be there, stony dullness. So this is the characteristic. Main normal thing is the resonant sound. If it is increased, it is called as a hyper resonant note. And if it is impaired, means it is decreased, then stony dullness can be there. And some books are written as woody dullness is also there. Some examiners won't like this woody dullness. It is given in, when you see the book Kundu, in that book it is written like woody dullness and all. But when you see the other books, it is not written this woody dullness and all. But you have to know this woody dullness, if they ask, you have to know where it is seen. Okay, stony dullness is seen in pleural effusion. Okay, now you have to do the percussion over the supraclavicular area. This area is also called as the chronic isthmus. Spelling of chronic isthmus, K-R-O-N-I-G-S. K-R-O-N-I-G-S. That is called as the chronic isthmus. This chronic isthmus is present where superior region. So anteriorly it is bounded by the clavicle. Posteriorly bounded by the trapezius. Laterally bounded by the acromion process. Medially by the scalene muscles. Anteriorly by the clavicle. Posteriorly by the trapezius. Laterally by the acromion process. And medially by the scalene muscles. This is the area where apical lobe of the lung is located. If some pathology is there at this place, you have to know that it is mainly apical lobe of the lung pathology. It may be fibrosis. Mostly the tuberculosis happens in the apical lobe because of the ventilation perfusion thing. So always remember this chronic isthmus percussion you have to do behind the patient. Chronic isthmus percussion is done behind the patient. You have to stand behind the patient and you have to do percussion. You have to do percussion starting from the acromia clavicular and then you have to go medially. So you have to stand behind the patient, you percuss, come medially. Okay. So start from the acromia clavicular joint. Acromia clavicular joint is there. You are starting the percussion, you do percuss, you come medially. So this is a percussion in chronic asthma. It should be done by standing behind the patient, and it should be started from the acromion process. Acromioclavicular joint, you come start, then you come to the medial aspect. It should be coming like that. And your the index finger, the middle finger, it should not touch the anterior aspect of touch the clavicle. It should be just behind the clavicle. It should not touch the clavicle. It should be behind your clavicle when you are percussing. So it should be from medial lateral to the medial aspect, and it should not touch your fingers. Should not touch the clavicle. So this is the rules of percussion. Okay. Now anterior aspect, 2 to 6 ribs. Mainly it is corresponding to the 2 to 6th rib. It is the anterior aspect. Lateral aspect is mainly 4th to the 7th rib is mainly there, and posterior is remaining things. Okay. Now posterior you can get everything actually, but mainly posterior lobe is posterior part of percussion, and everything is mainly related to the lower lobe things. The axilla is mainly related to the middle lobe thing. Anterior aspect and the upper part is mainly this is mainly for the apical lobe of the lung. And you have to know there is 2 more things are done there in percussion in respiratory system alone. That is a tidal percussion and trough space. Tidal percussion, TIDAL, tidal percussion, and trough space, TRAUBES, trough space. So this tidal percussion, it is done in the right side. Trough space is done on the left side. So the tidal percussion is done to differentiate between supradiaphragmatic and infradiaphragmatic pathology. Supradiaphragmatic and infradiaphragmatic pathology. So how to know when you are doing percussion, you do percuss. When you come to the 5th intercostal space, you will feel the dullness. That is the normal liver dullness you are getting. You are getting the normal liver dullness. Now you tell the patient to take the deep inspiration. What is going to happen? When you take the deep inspiration, your diaphragm was here. The diaphragm is going to come down. Till now, I was doing percussion here. I was doing the percussion. I was getting dullness. That time the liver was there. When I tell the patient to take the deep inspiration, the diaphragm was pushing the liver down. Diaphragm came down. Now, if I do percussion here, what is going to happen? It will become a resonant note. So the differentiation is between now the problem. Now you can get that the problem was because of the liver. Suppose the problem now also when the diaphragm came downwards, you are getting dullness on percussion here. That is what is the meaning of that? The problem is above the diaphragm only, because the diaphragm already removed down. There is no infradiaphragmatic problem. The problem is above the diaphragm. So what is maybe the problem above the diaphragm? It can be there. It can be some pleural effusion, or it can be some lower lobe pathology of the lung. It can be there. So if that is there, when the lung is pushed down, also you are getting dullness on percussion. Doing the tidal percussion, it is supradiaphragmatic pathology. If it is an infradiaphragmatic pathology, or if it is normal, it will lead to resonant sound after doing the tidal percussion. Now you understood? No? Okay. Now there is something called the trough space on the left side, similar to that. Trough space, TRAUBES, trough space. This is bounded superiorly by the lung resonance, inferiorly by the costal margin of the lung, and the lateral aspect it is by the spleen, anterior aspect of the spleen. The medial aspect is by the left lobe of the liver. The boundaries are upper part is by the lower lung resonance on percussion, lower part is by the lower costal margin, medial aspect is by the left lobe of liver, the lateral aspect is by the spleen. Lateral aspect is by the spleen. So what is present in this trough space normally? Normally the fundus of the stomach is present here. Normally the fundus of the stomach is present at this trough space. So when you do percussion, if the trough space is appearing dull, it can be normal, it can be abnormal. Normal can be full stomach. You went for some food outside. You had some full stomach food. You came inside and you are sleeping. Your friend is coming and trying to learn the percussion. You will automatically get a trough space dullness because of the full stomach. One is full stomach. It's a normal physiological thing. Second thing, in fundus of stomach, if there is some carcinoma is there, that can also lead to trough space obliteration. Now, if there is any of the boundaries are affected, suppose the medial boundary, like left lobe of liver is enlarged, or there is a splenomegaly has happened from the opposite side. Left lobe of liver is enlarged, or the splenomegaly has happened from the opposite side. Or it can be some massive effusion, pleural effusion is there. Or it can be some lower lung mother pathology. All this can lead to trough space obliteration. So you have to know trough space is on the left side, tidal percussion is done on the right side. You have to know this common basic thing. Okay. Now, when you do the percussion, if you get some other abnormal sounds, like crackpot resonance can be there. Crackpot resonance. It is mainly seen in cavity, C for C. Cavity will lead to crackpot resonance. Crackpot resonance it can get. When you do the percussion, if the tenderness is very high, it can be because of empyema. Tenderness can happen normally also for everybody, but if it is very much high, it can be because of empyema, or it can be because of an inflammation of the parietal pleura, or it can be because of an inflammation of the parietal pleura. Sometimes if there is a post-herpetic neuralgia, if they have, when you do some touching itself, they will get a pain. That can also lead to vein on touching. And another thing is hydropneumothorax is there, something called hydropneumothorax. Hydro is water, pneumo is air. So when you see the X-ray and all, you can see something called some straight line, water fluid level will be seen. So they will have something called shifting dullness can be there, straight line dullness and all can be there. Normally they say this pleural effusion, the fluid collects in a S-shaped curve. Like in the axilla, it will be like an upward area, and in the lower area, it will be as a straight. So it will go like a curve. That is called Ellis, E-L-L-I-S. Ellis S-shaped curve. This is mainly seen in pleural effusion. But in hydropneumothorax, when you do the percussion, you can get something called a straight line. Everything is straight line because there is an air fluid level is there. The straight line dullness will be the feature of shifting dullness is the feature of straight line dullness is the feature of hydropneumothorax. Something called shifting dullness is there. First you do percussion here. Now you tell the patient to lay down on supine on one side. Then you do percussion. The sound will get changed. The location of the sound is changed. That is called as shifting dullness. Now previously you are getting the dullness here. When you tell the patient to lay down, that will be changed. The position is changed. That is called as a shifting dullness. So shifting dullness and straight line dullness, these are mainly present in hydropneumothorax. Okay. Now you have to know that there is something when you are coming to the auscultation. Now we'll go to the auscultation area. Auscultation. Okay. So auscultation also you have to first tell about the breath sounds. You have to put the column right, left, every auscultatory areas you mention. Then you tell next thing you have to mention. You put the next column and then you put the vocal resonance. There also you divide into right and left. You may elaborate all the areas like supraclavicular, infraclavicular, mammary, suprascapular, axillary, infraaxillary, suprascapular, interscapular, infrascapular. All the areas you mention and you tell write the how is the breath sounds. Whether it is normal vesicular breathing or the bronchial breathing, followed by vocal resonance, followed by any added sounds. This is how you are supposed to write the case sheet. Your case sheet should be around 7 to 8 pages at least when you write an RS case. If you write a CNS case properly, you will have at least 10 pages case sheet. So you have to practice out writing the case, taking and writing the case, everything in 45 minutes. But due to the COVID things and all, sometimes exam may become online. Like they may give you case scenarios because nowadays MD exams, DM exams, they were conducting in that way. Like they were giving case scenarios. The COVID thing is not settling down soon. So case scenario, they will write the history of the patient. They will write the examination findings. Then it will become like an OSCE. It may become like that. We don't know. So if the exam is like this, anyway, if you are an MBBS student, you may need it for your MD time at least. For that time there is no COVID and all will be there. You have to know the clinical medicine properly that time at least. So even if it is X-ray, ECG, everything will give you all the diagnosis. Still clinical, we cannot order X-ray for everybody. Some patient is very poor. Patient is coming with a cough. If you are writing X-ray in that village area, they will tell that you are very much bad doctor. This will happen. So always try to know the basic things like some percussion. If you do, you can know what is some pathology is there or not. Auscultation you do, you will get. And not taking the direct X-ray is not the diagnosis. Okay. Now coming into the auscultation, if you tell the auscultation, normal vesicular breath sounds and bronchial breathing, two types of breathing breath sounds can be there. So vesicular and bronchial, what is the difference means? In vesicular, the inspiration will be longer and expiration is very shorter. Expiration is very shorter. That is the vesicular breathing. And there is no gap between inspiration and expiration. They will tell you to draw the diagram of bronchial breathing, vesicular breathing, and different type of pulse you have to know. And you have to know different type of murmur, how to draw the images. These things you must know to draw also. Okay. So vesicular breathing, expiration will be just 1/3 of inspiration, and there is no gap between inspiration and expiration. You tell the patient to take the breathing, you remember of this thing, then you will hear whether it is a bronchial or vesicular. To hear a bronchial breathing, you can keep your stethoscope over the tracheal region. You can hear something called bronchial breathing because it's not a filtered sound. So when it becomes a vesicular breathing, is the expiration. Expiration is 1/3 of inspiration. There is no gap is there. If you are telling about the bronchial breathing, the inspiration will be equal to that of expiration. In the inspiration duration is equal to that of an expiration, and there is a gap is there between this expiration and inspiration. Expiration and inspiration, there is a gap is there. This is what is called bronchial breathing. This is what is called bronchial breathing. So this bronchial breathing you can get even in the upper vertebrae if you auscultate also, upper thoracic vertebrae also if you auscultate, you may get a bronchial breathing sometimes. So next thing is you have to know there are types of bronchial breathing. They are tubular, cavernous, and amphoric. Tubular, cavernous, and amphoric type of bronchial breathings. So what is this tubular? Tubular type of bronchial breathing. For example, when you are telling something like, if you take a ha sound, ha sound, if you are hearing, that is mainly tubular type of bronchial breathing. Tubular type of bronchial breathing. It's a high pitched sound, like ha, like that you will hear. If you are telling like something sound like ooh, that ooh sound, this is mainly cavernous type of bronchial breathing. Cavernous type of bronchial breathing is the one that is mainly low pitched sound. Cavernous type of bronchial breathing is a low pitched sound. It will look like a ooh character. Like this, I am mimicking. Okay, it is not that in exam or you don't want to tell that it is a hoo sound or ha sound. So you tell it's mimicking. When you are mimicking, you are here. It is for your easy purpose thing. If it is hearing like a ooh thing, you need to know it is a cavernous type. If it is looking like ha type, that is a high pitched sound. In exam, these theory things, high pitched, low pitched, and all, you will not understand if you are telling like that. So this ha sound, that type of character, if it is hearing, it is mainly the tubular type of bronchial breathing. For example, in olden days and all, in kitchen, we will use that this thing, no, to make the blow the firewood. For that sound will be there. That is called as the similar to the tubular type of bronchial breathing. So you have to know which are the conditions. There is some metallic character sound is there, that is called as the amphoric sound. Amphoric type of bronchial breathing. It's some metallic character is super added to that. That is called as metallic sound is also present. Then it is considered as amphoric type of bronchial breathing. Okay, so this cavernous for C. So cavity, cavernous. Another thing was crackpot resonance on percussion. Cavity. So cavity, it is cavernous, and it is mainly seen in crackpot resonance also was there in cavity. So, and also you can see it in pneumothorax also. You can also get this in pneumothorax also. That is a cavernous type of bronchial breathing. But in exam, usually pneumothorax won't keep. It's not possible to keep because patient will suddenly collapse. So if some pneumothorax is happened for somebody, what to treat? Wide bore needle should be taken. It should be inserted into the intercostal space. So the needle, it will all the air that got accumulated will go out. So patient will be saved. This is the emergency procedure you have to know. Some otherwise, and main treatment of choice is mainly the ICD, that is the intercostal drainage tube insertion. Okay, exam hall they may ask you these things. So tubular is mainly seen in consolidation. Tubular is mainly seen in consolidation is what? It's a pneumonia only that is called as consolidation. That is stages of pneumonia. Okay, so stages of pneumonia you will hear like stage of congestion, stage of red hepatization, stage of gray hepatization, and stage of resolution. So 4 stages of pneumonia will be there: stage of congestion, red hepatization, gray hepatization, and resolution. So these 4 stages of pneumonia. In this red and gray hepatization stages, you will get this bronchial breathing. You won't get in the other 2. In early stages, that is stage of congestion, you will get mainly the fine crackles. Stage of resolution, you will get what is called as the coarse crackles. Stage of resolution, you will get the coarse crackles. Stage of congestion, you will get the fine crackles. Okay, so this is the thing you have to know. Stage of red and gray hepatization, you may get a bronchial breathing. That is a tubular type of bronchial breathing. If there is a superficial cavity, if that is there, or if there is a bronchopleural fistula is there, that is leading to amphoric type of breathing. Amphoric type of breathing, then there we will get mainly superficial placed cavities or bronchopleural fistula. And pneumothorax also it can happen sometimes. It can lead to this also. So always you mainly need to remember the one that is called as the tubular type of bronchial breathing. Mostly this is the one that you are going to see, not the other things. Next thing you have to know is that vocal resonance. How is the vocal resonance? Whether the vocal resonance is increased or decreased, you have to tell. When vocal resonance is increased, mainly it may be because of cavity or it may be because of consolidation. Consolidation is solidification of the lung parenchyma. So olden days you might have kept your head like this and you might have tapped over the table. That may lead to increase in the sound. That means solid is a very good conductor of sound than air. So that is why when there is a consolidation has happened, now there is solidification of the lung parenchyma has happened, you will get an increase in the vocal resonance. When vocal resonance is increased, you are supposed to check any other particular character for that vocal resonance. This vocal resonance will be decreased in fibrosis and all, but some people tell fibrosis there is a variable character can be there based on parenchyma is there and pleura is there. If the parenchyma fibrosis alone is there, you know pleura is the covering of parenchyma. So if there is parenchyma fibrosis alone is there, it can lead to increase. If there is only pleural fibrosis is there, means it can lead to decrease in the vocal resonance also. So now there is something what I told is bronchophony, egophony, and whispering pectoraloquy. These things you are supposed to examine when the patient is having an increase in the vocal resonance. Bronchophony, egophony, and whispering pectoraloquy. So bronchi means each and every syllables you will hear it in a louder way, but thus it will not be distinguishable. If I am telling Chakravarti, that Chakravarti, each syllables will not be differentiated. I will just hear it as an increase in the sound, that is bronchophony. And it will hear as if that individuals, if it is coming from the ear itself, it is coming from the earpiece. And whispering pectoraloquy, if it is telling, if I am whispering something itself, that each and every syllable is hearing a separate words. Separate alphabets are hearing separately. That is what is called as whispering pectoraloquy. Whispering pectoraloquy. Bronchophony, this will not be separately hearing, but when whispering pectoraloquy is there, you will hear each and every syllable separately. And egophony. What is egophony? You tell the patient to tell E, you will hear it is A. Patient is telling us E, but in your stethoscope you are hearing it as A. That is bronchophony, egophony, and whispering pectoraloquy. This is mainly seen in consolidation and cavity. Mainly seen in this, all three things are mainly seen in consolidation and cavity. But one more condition is there. just above the level of pleural effusion. There is pleural effusion is get collected just above the level of pleural effusion. Immediately above region, this area, you can get this increase in the bronchial or vocal resonance can be there. This particular characteristics also can happen in that region. So that is the main thing in vocal resonance. Next, coming to the added sounds in respiration. Added sounds means where it is crackles and rhonchi or pleural rub. Only three things you need to know. Crackles can be inspiratory crackles or expiratory crackles, or it can be fine crackles or coarse crackles. Fine crackles, if you want to hear, you can just, if your hair is dry, you just do like this. What sound you are hearing, that sound is what is called as a fine crackles, fine crackles. If you do the coarse crackles, you can like sound. That is what is coarse crackles. Some already collapsed alveoli, now we're getting filled of secretions. If it is there, it can happen. Or air is passing into the alveoli. That can happen like this. This is what is the mechanism behind this crackles. Crackles, okay, or crepitations, okay. Now, these crackles can be divided into early inspiratory, mid inspiratory, and late inspiratory crackles. Early, mid, and late inspiratory crackles. Okay, so I will draw and show you how is that means. For remembering easy purpose, it's not a mechanism at all. So this is the image you see. So early, what is the bronchi? So when the bronchi is affected, that is bronchitis. That is early inspiratory crackle. When the bronchiole, if it is affected, that is the mid inspiratory crackles. That is bronchiectasis leads to mid inspiratory crackles. And late inspiratory crackles. Late inspiratory crackle means alveoli. So in alveolitis or interstitial, here is interstitium is there. So all these interstitial areas. So interstitial fibrosis. These are the causes of late inspiratory crackles. Remember, early it is the bronchi. Bronchi, if it is coming, that is the bronchitis. So early inspiratory crackle. Mid inspiratory, it is the bronchiole, bronchiectasis. Late inspiratory, it is the alveoli. So alveolitis and interstitium is also present in the late aspect of this picture. So remember, interstitial fibrosis also mainly seen in late inspiratory crackles is the reason. Okay. Now, this is the common thing. Coarse crackles, you need to know that it can happen in pulmonary edema, it can happen, or it can happen in like resolving pneumonia, late stages of pneumonia. Early stages of pneumonia, you will get fine crackles, while late stages of pneumonia, you will get the coarse crackles. And there is something called death rattle. Initially, I told you death rattle. That is mainly seen in pulmonary edema. You can get something called a death rattle, coarse crackles. And another thing is Velcro crackles, Velcro leathery crackles. You take your chappal strap, some footwear will have a strap, you know, you take that sound. That sound is there, no? When you remove it, that is called as Velcro leathery crackles, Velcro leathery crackles, VLCRO, Velcro leathery crackles. This is mainly seen in interstitial lung diseases. This is mainly seen in interstitial lung diseases. Now, pleural rub. How to know that it's a pleural rub or not? It is mainly present in the inspiration and the expiration, both it will be heard, and it will be like a rubbing sound. And this is mainly present in the lower aspect of the axilla. Lower aspect of the axilla is the commonest area where you will get the pleural rub. And it is not heard when the breathing is stopped. This is how to differentiate between pleural rub or pericardial rub. Pericardial rub, if it is there, it will be rubbing even if you stop the breathing, no? Because the heart, you cannot stop breathing. But if it is a pleural rub, once you stop the breathing, that will get disappear. Okay? And another thing you have to know that there is something called the post-tussive crackles, post-tussive suction sound and all that. This is mainly seen in cavity. Just wanted to tell for completion sake, like at the if there is a cavity is there, after the cuff, the character of the crackles will get changed. That is post-tussive crackles. Post-tussive suction sound. After cuffing, there is a sucking sound will be there. That also can happen when there is a cavity, if it is there or not. And next, how to differentiate. Now we are coming to the end of this auscultation part. So how to differentiate whether there is a consolidation is there or everything is there. First, trachea. Trachea will be there in the midline in case of consolidation and COPD. Trachea will be deviated. towards the side if it is collapse or fibrosis. Trachea will be deviated away from the lesion if it is effusion and pneumothorax. And when the vocal fremitus will be increased in consolidation, and collapse and fibrosis, usually it is decreased, and fibrosis sometimes it is written variable also. And in COPD, it will be decreased. COPD, vocal fremitus will be decreased, and in pneumothorax and pleural effusion, it will be decreased. Pneumothorax, pleural effusion, it will be decreased. So vocal fremitus and vocal resonance, both of these are together always. So vocal fremitus and vocal resonance both will be increased in consolidation, and collapse it will be decreased, and fibrosis it will be variable, and usually it is diminished. And COPD, pleural effusion and pneumothorax, it will be diminished. And you have to know the percussion. Percussion, there will be dull note on percussion or impaired note on percussion, or somebody will tell woody note on percussion. This is mainly seen in consolidation. Consolidation will have impaired note on percussion. Somebody asks you, then you tell it is woody note on woody dullness. Don't tell the word dullness. Otherwise, you write it is impaired note on percussion on consolidation, and collapse and fibrosis will be dull note on percussion. And emphysema will have hyper-resonant note on percussion. Emphysema will have hyper-resonant note on percussion. And effusion and pneumothorax, effusion will have a stony dullness on percussion. Effusion will have stony dullness on percussion, and pneumothorax will have a hyper-resonant note on percussion. Pneumothorax will have hyper-resonant note on percussion. And coming to the breath sounds will be bronchial breath sounds will be seen in consolidation, but breath sounds will be decreased in fibrosis, and it will be absent in collapse. Fibrosis it will be diminished. And COPD also it will be decreased, and the expiration will be more compared to inspiration in case of COPD. Expiration will be more compared to inspiration in COPD. And in pleural effusion and in pneumothorax, you will hear decreased breath sounds. Decreased breath sounds you will hear in pneumothorax and pleural effusion. And if you see the bronchophony, echophony, all these things will happen in consolidation. This will not happen usually in other conditions. Okay. And just above the level of pleural effusion also, you can hear rarely. And added sounds, usually consolidation will have early stages will have fine crackles. Later stages you will have mainly coarse crackles. Fibrosis also you can have a crackles which is of course in nature. And emphysema or COPD you will get mainly the rhonchi will be there. And effusion, pleural effusion, usually the added sounds are less likely to hear, and usually sometimes rarely you can get a pleural rub can happen in effusion. And pneumothorax, sometimes there can be that rhonchial breathing, metallic sound can be there. Metallic sound of bronchial breathing can be there. Otherwise, you are not going to get any other other sounds in pneumothorax. Less likely to get any other other sound. Usually, the sound will be decreased or absent breath sounds will be there. So now we are coming to the end of the session. And when you are telling the diagnosis in case of an RS case, you have to tell like what is the etiology, like your anatomical diagnosis should be there, etiological diagnosis should be there, and your pathological should be, everything should be there. Like if you are telling like a left upper lobe fibrosis, probably because of tuberculosis in etiology you will tell. You have to tell any complications are there, like if the patient is having cor pulmonale is there or not, you have to mention. Respiratory system, like, and if you are telling about pleural effusion, you can tell that never tell pleural effusion like a lower lobe pleural effusion, upper lobe pleural effusion, middle lobe pleural effusion. There is nothing like that. You need to tell like a mild, moderate, and massive pleural effusion. When you are getting up to the second intercostal space, you are getting with the midline shift is there, it is always the massive pleural effusion. And moderate will be other cases that is kept for you. Small, mild pleural effusion, usually nobody will keep for your exam. You cannot recognize it easily. Okay, so moderate pleural effusion, massive pleural effusion you should know. And you need to tell what is etiology of that. Tuberculosis, because the respiratory system, mostly the etiology is tuberculosis, because in India, the most common pathology is mainly tuberculosis. Okay, now when you are telling about serious cases, you need to tell about whether any whether because of infective endocarditis or it is a because of any atherosclerotic etiologia, or it may be rheumatic in etiologia, whether the patient is having a congestive cardiac failure is there or not, whether the patient is in sinus rhythm or not. Like CVS, you have to tell like that. When you are telling about abdomen case, you need to tell that it may be chronic liver disease. Never tell cirrhosis or liver as diagnosis, because cirrhosis is actually a pathological diagnosis. Many people will not like if you tell cirrhosis as the diagnosis. You need to tell that it is a chronic liver disease, probably because of a chronic alcoholic in etiology, and you need to tell that whether patient is having liver cell failure is there or not, with or with massive ascites or moderate ascites. How is that? Then you need to tell that whether patient is having liver cell failure. Similarly, in CNS also, you need to tell that whether what type of stroke is that, like left hemiplegia or right hemiplegia or paralysis with where is the lesion, whether it is a right, whether it is a left middle cerebral artery tertiary or right middle cerebral artery tertiary or anterior cerebral artery tertiary, which artery, which branch can involve. If you tell that also, it will be good. And you need to tell that what is the etiology behind that, whether it is hypertensive bleed has happened or what is the reason, atherosclerotic in etiology. So always when you are telling the diagnosis, you need to tell the complete thing. Okay, so we will conclude the session. Thank you.
Dear members, any doubts or any clarifications are there, you can ask the mentor. Some things Dr. Jithin made very clear. We really appreciate that, especially the holistic approach of a system. He's starting with the importance of even the oral cavity he mentioned in case of a CVS case or a respiratory case. Each and every part or each and every step in examination is very important. He stressed each and every part very clearly. That's the one thing very important which we have to learn, take home message from this session. Holistic approach to the system or examination. Second thing, like you mentioned at the end, the how to tell a diagnosis. Okay, some examiners particularly doesn't like the pathological diagnosis at the end, only anatomical, etiological, and more you can tell at the end. If they ask what it could be, then if they prompt you, then sir, most common cause is this thing, cirrhosis, so it can be this, you can tell. Otherwise, unless they ask you, don't tell by yourself the pathological diagnosis, because they can be only examined under microscope and then we can tell, not clinically. So very wonderfully said. Very enlightening class today. Any doubts you have, you can ask. Chat section, they're having some doubts. Jithin, can you please?
Somebody has asked regarding fibrosis and consolidation. So consolidation is actually the solidification of the lung parenchyma. Fibrosis means it is a fibrotic stance are happening. Consolidation is usually an acute process. That means after an infection like a pneumonia, if it is happening, they will develop. And after a few months, it will get resolved off. So fibrosis, once it is happening, it is not going to resolve it back. It is usually an indicator of an old mechanism. It's because of an like old tuberculosis. If it has happened, that is the reason for regarding the fibrosis is happening, and fibrotic stance will be there. That is the reason for fibrosis. And another question was like, what is the difference between crackles that can happen in fibrosis? And usually books are written like fibrosis can happen fine and cross crackles both can happen, but usually it can be coarse crackles. Some books are written as fine also. But fibrosis, usually we will not get a crackles also, that can also happen. For an inexperienced years, you will not get. So better not to tell that you can hear a crackles. You can just tell it is a diminished sound until unless you are very confident that the crackles are there. And another thing is that some mechanical, in diaphragmatic palsy, what will be the chest movement? Somebody has asked. In diaphragmatic palsy, there is something called paradoxic respiration can happen. Paradoxical respiration means like when the patient is breathing, usually the diaphragm will come down, your abdomen will move up. When there is a diaphragmatic palsy is there, when you are taking the breathing, diaphragm is not moving down. That means it's not pushing down. So that what is going to happen? It is going to pull the it is going to pull the abdomen inwards. That means the abdomen will not come out. That is what is called paradoxical breathing. We are examining mainly in neurological cases for paradoxical breathing, like a diaphragmatic palsy. It can happen in neurological diseases mainly, not in respiratory system alone as such. And another thing is like mechanism of sounds in the respiratory system. So the sound is produced to the bronchial, vocal cord is producing, it is getting filtered through the bronchus, usually the filtering system. So if the filtering system is normal, then only if the filtering system is normal, you are hearing that the vesicular sounds. If the filtering system is not normal, that filtration is not happening towards the outside, so you are getting the bronchial breathing as such. when the consolidation has happened, it can happen. When the fluid is present there, that fluid is preventing the sound to come to the skin of the to the auscultatory area of the stethoscope. So that fluid or something mass is present, it is preventing that. So there it will be decreased. It is mainly the filtration mechanism of the bronchial tree. And another thing was pathology of near drowning. Actually, even I am not sure about the pathology regarding near drowning. What is important is respiratory system is, if somebody has regarding developed near drowning, they will have mainly that aspiration. Because of that reason I told. But near drowning exact pathology mechanism, I am not remembering exactly. There is like some salt water and fresh water. Based on that, the osmosis changes will be there because of that actually. But regarding to how to trace Ellis curve. Ellis curve is actually, it is, you will get only in X-ray. It is not seen in clinically.
It's a radiological finding. Yeah,
it's a radiological finding. That also some people are telling it's a radiological illusion, or it can be because of capillary suction. These are the two mechanisms they will tell for Ellis S-shaped curve. It is mainly X-ray wise, not by clinical wise. How to clinically differentiate whether it's a bronchial breathing or normal vesicular breathing. That is why I told you initially, when you are hearing it properly, you hear that there is a gap is there or not. You auscultate. When you auscultate, if inspiration and expiration you auscultate clearly, the duration of inspiration and expiration, both you mind it clearly, then you feel that if both are equal duration, that is a bronchial breathing. And there is a gap is there. If gap is there, then only you can call it as a bronchial breathing. Okay. So bronchial breathing means that there is a gap will be there, and inspiration and expiration both will be same. And somebody asked woody dullness. Woody dullness is actually the impaired note in percussion on consolidation that is labeled by some of the authors as a woody dullness. There is nothing else separately. It's an impaired note on percussion that is in consolidation. That is what is meant by woody dullness. So only in that Kundu book it is written. All other books are not mentioned. It usually as woody dullness.
see, all these things, examination can be learned only by practicing more and more. What is a Jithin? It cannot be learned over by listening like this or reading books. How possible as possible. As many normal, maybe normal bets on what normal is, let's understand that. Then abnormal one by one, you will try to understand easily. Normal pulse pattern, try to palpate as many pulses as possible, feel for them. Then automatically the abnormal things will fall into place. Don't worry about abnormal things. For undergraduates, do you expect all abnormal respiratory heart sounds to be known? Dr. Jithin, what do you feel as examiner? Do you expect them to know everything, or basic? If they tell it's a vesicular or bronchial, that much is enough for them.
If you tell
or a systolic murmur for that in a CVS, maybe a systolic or diastolic murmur.
This is based on the examiners. For example, if it is a young examiner, they will usually accept it. But old examiners, they are very particular in regarding these things. Like they want particular murmur to be told. All examiners particular because they were using only the stethoscope for diagnosing everything. Now the young examiners that they know that everything will be diagnosed by, even if you find there is a murmur is there. In clinical life, if you don't know to diagnose, it is not an issue. You know to know it is abnormal, that is enough. But when you to pass the exam, you need to know better, and for knowing reducing the cost of the patient, you need to know it better. Otherwise, if you know some abnormal sound is there, you can ask for an X-ray, it will come. So that is the main thing. And one more question, somebody was asking chronic isthmus. So chronic isthmus means it is anteriorly bounded by the clavicle, posteriorly by the trapezius, laterally by the acromioclavicular joint, and medially by the scalene muscle. This is the chronic isthmus. Here is the area where apical lobe of the lung is located. When you do the percussion, you have to stand behind the patient, and then you have to do percussion from lateral to medial. You have to percussion from lateral to medial by standing behind the patient. Anything else? We'll wind up. Kishan?
If no other questions, thank you so much, Dr. Jithin, for your valuable time and inputs.
Okay, thank you.
Hope to get some more classes of your interest, maybe neurology classes soon. We are eager to listen from you. Okay. Yeah, on behalf of all the members of the White Army, wholeheartedly thank you. Thank you so much. We are really grateful to you. And whenever you are at your convenience, whenever you feel free, please consider to take some classes for us.
Okay.
That's all our request from our side.
Okay,
Yeah,
okay,
thank you so
okay.
much.
Okay.